some areas of red within, where the red is the lesion and not like normal tissue showing through red. So I brought some examples, and this one is very subtle, but the lesion is kind of spread out. This part is white, doesn't wipe off or scrape off, and this part is red. It looks like an inflammatory lesion. So this is one where you might need to follow our protocol of eliminate local factors if you can find any, and reevaluate to see if it's still there or see if it's healed. How long do you wait to reevaluate? 2 weeks, no more than 2 weeks, no less than 10 days. Why is it no less than 10 days? Because if it was related to trauma or irritation, it's going to take that long to heal. So you have to give it time to heal, but you don't want to go over 2 weeks because this could be something that needs attention. The red changes are always more advanced, and so if we see a lot of red, we don't even have to wait the 10 days. If we can clinically exclude the possibility of local irritation or inflammatory condition. The patient on the right has a large, well-demarcated lesion that's mostly red. It's non-tender, no symptoms, but it does have some areas of white. This is one that I would not wait 2 weeks. There are no signs of inflammation. Inflammatory things are usually tender or painful. So the fact that this is painless and is persistent, it's been, the patient knows it was there before, I would send this patient for immediate biopsy. I wouldn't wait 2 weeks. So both of these were biopsied, and they both had carcinoma in situ in them, and the carcinoma in situ is virtually always in the red area. It's very unusual for it to be the white part. 2 more patients. These are red lesions only. Macular, you notice that there's no mass there. It's just flat, normal contours, but it's red. That's when we call it erythroplakia. It also doesn't scrape off, although it doesn't look like it would anyway, because it doesn't look like it's red on top. It looks like the color change comes from underneath. Both of these were painless. No local factors could be identified that would be causing irritation or inflammation there. So erythroplakia fits. Can't be clinically characterized as any other disease process. When we have erythroplakia, it has very, very high risk of already being malignant or at least carcinoma in situ. And these are ones when we have erythroplakia like this, we send for immediate biopsy. We do not wait for 2 weeks. Certainly, this is one of those types, clinical patterns of lesions that requires immediate attention. And this one actually had early invasive squamous cell carcinoma. So what does early invasive squamous cell carcinoma mean? I think I defined it last time. It means there's only microscopic invasion. It's just minimally invasive, so you wouldn't have any clinical signs of a mass or the other things that we would associate with an invasive tumor. So it still just looks like a red patch, but when it was biopsied, they could see invasion. Just a little tiny bit, just a few cells is all it takes to still be invasive. So we call that early invasive squamous cell carcinoma. So we move on past our clinical presentations to the actual diagnostic entities, the diseases. These are if I ask for a diagnosis, these are the diagnoses that you can use. Because leukoplakia, erythroplakia, speckleukoplakia are not diagnoses. They're clinical appearances. A short, quick word for a clinical appearance. Have we had that concept previously in this course? Yeah. What's an example of a clinical presentation that has a special name, but it's not a diagnosis? Desquamative gingivitis, absolutely. Not a diagnosis, but a few words mean a lot and convey a meaning of the clinical presentation. So the first thing on our actual diagnoses is benign keratosis. Some people call this hyperkeratosis. You can use either term. I was always taught that hyperkeratosis is a histologic descriptive term and benign keratosis is the diagnostic term. but it doesn't really matter. What benign keratosis means is that there is excess keratin at the surface, and that's what's producing the white changes that are present clinically. But the epithelium underneath the keratin is normal. It might be a little hyperplastic, it might be thicker, but there's no cellular atypia. There's no dysplasia, there are no premalignant changes. And that's why we say benign. It's totally benign, not premalignant yet. It still could become malignant over time. At least 20% of these over time do become malignant in patients who have risk factors for oral cancer, and even patients who don't have risk factors. So it's kind of an interesting thing. This is a patient who is a heavy smoker. You see a little tobacco staining on the teeth. That is an upside down picture. I don't know why I have that upside down, but he's standing on his head. But the cheek mucosa is thickened and white and wrinkly on both sides, kind of has that leathery look. Even the dorsal tongue looks a little bit leathery, so it's kind of an interesting thing. But those are good examples of benign keratosis. So sometimes it can be very diffuse, and sometimes it can be very localized. This is a patient on the left who has an edentulous ridge where teeth are missing. And come on, pointer, there it is. One of the first things that we have to think about is this alveolar ridge keratosis, frictional keratosis on the alveolar crest from eating without any dentures and kind of functioning directly on the tissue. Do you think this fits with alveolar ridge keratosis? No, because we have the white that extends into the movable mucosal area, into the floor of the mouth, into the buccal vestibule. So something else is going on. So then we want to know, well, does this patient actually wear a partial denture that is rubbing these areas? And as it turned out, this patient did not wear a partial denture that was rubbing these areas. So this was an idiopathic white patch that couldn't be characterized as anything else, didn't have any reason to be there, not a frictional lesion. So that puts us into a different spectrum. When it was biopsied, it was benign keratosis. Question?
How would this be different from linea alba?
Linea alba is on the cheek at the occlusal plane. It is location specific, exclusively location specific. This is a patient who has a white patch in the palate. Kind of an unusual place to have a white patch that won't wipe off and can't be clinically characterized as any other disease, but it was there. Because that's an unusual location, it was biopsied and it was found to be benign keratosis. So the only abnormality was the extra keratin on top. If you look at both of these cases, you can see that it looks like something just stuck on the surface, which is very typical for benign keratosis. The white patch looks like it's sitting just right on top, not white from underneath. Does that make sense? Yes. Question?
So is this a form of, is it leukoplakia?
They present as leukoplakia clinically, so that's how we would describe them in terms of their appearance.
Okay.
But the diagnosis is benign keratosis. So one of the things I'm going to ask you to do is interpret clinical lesions and come up with a differential diagnosis. So you can't put leukoplakia on your differential because it's not a diagnosis. So when you see a leukoplakia, you build your diagnosis based on what we know from biopsy studies, that 80% of them are benign keratosis and most of the rest are keratosis with dysplasia. So you build your differential with the things that we know statistically are the most likely diagnoses. Yeah, that's how we go about it. Here's another one, floor of the mouth, several little white patches, look like they're stuck right on top. We get pretty worried about them in this location because that's a higher risk site for oral cancer. But biopsy showed it to just be benign keratosis, just kind of what you would expect for a white patch. This one's lateral border of the tongue, leathery white patch, fairly well defined. And it was also benign keratosis, and that's also a high risk site for oral cancer. Not a lot of things produce frictional irritation that could produce a frictional keratosis in the floor of the mouth. That would be hard to do. But lateral tongue is a common place for frictional keratosis, from rubbing against sharp teeth or sharp restorations or things like that. So anytime we have lesions on the tongue, we do need to clinically carefully evaluate for the presence of something that could be causing chronic mechanical irritation. And when we eliminate that possibility, that makes it a leukoplakia, and then we're building our diagnosis based on that. And single most likely diagnosis for a leukoplakia presentation is benign keratosis. Question?
Professor, so would you say that it basically happens in all oral mucous membranes since it's how they...
Leukoplakia can occur anywhere in the mouth. It's more common in some places, but it can occur anywhere. Good question. So the prognosis for benign keratosis is very good for now, and it's not premalignant. It's normal cells, just excess keratin being produced. But early studies showed 5 to 10% risk of becoming malignant over time. More recent studies show up to 36%. They didn't update this, but it's like 20 to 36%. So getting a diagnosis in the benign keratosis stage of disease is the best time to eliminate any carcinogenic exposures. This is when we tell patients, stop smoking, stop drinking, don't use sanguinaria, don't use betel quid, all of those things. Get rid of them. Cross your fingers that this will never progress. Question?
Knowing that oral hairy leukoplakia has an underlying possible cause of someone who's immunocompromised, how would I be able to know when to write benign keratosis as opposed to oral hairy leukoplakia?
Oral hairy leukoplakia has a distinctive appearance with the little finger-like extensions at the edge and the little corduroy appearance. This part sort of looks like it, this part doesn't, and it's virtually always bilateral. Virtually always bilateral.
Which one is bilateral?
Oral hairy leukoplakia. So we don't usually get them confused.
Okay.
Don't usually. If this progresses, it normally goes through the pathway of dysplasia next, might get carcinoma in situ, and then squamous cell carcinoma, or go directly from dysplasia to squamous cell carcinoma. Sometimes it can develop kind of thick finger-like projections on the surface and become somewhat verrucous and progress to verrucous carcinoma, which is a special variant of squamous cell carcinoma that we will talk about. So we move on to our next diagnostic entity, which is our epithelial dysplasia. You can also call this keratosis with dysplasia. You cannot call it benign keratosis with dysplasia. That's a contradiction in terms. So you either call it epithelial dysplasia or keratosis with dysplasia. But we are going to have excess keratin at the surface. It can be regular keratin or parakeratin with persistent nuclei. And we are going to have atypical cytologic features. So we're going to have cellular enlargement, hyperchromatic nuclei. We are going to have hit the wrong one. We are going to have variation in size and shape from one cell to the next. There's a word for that. What's the word for variation in size and shape from one cell to the next?
Dysplasia.
Not dysplasia. Not metaplasia.
Ask the question.
It's pleomorphism.
Oh,
Pleomorphism, many appearances. So we have cells right next to each other that should be uniform in appearance, but there are many different appearances. So we have some pleomorphism and some hyperchromatism. But the key thing with dysplasia is that we have failure of maturation. So as the cells migrate to the surface, they're not maturing and getting smaller and developing normal keratin. They're staying large and primitive as they migrate to the surface. We can even have mitotic figures above the basal cell layer. So that's when we call it dysplasia. And we give dysplasia grades, mild, moderate to severe, depending on what thickness of the epithelium is involved. If it's a basal 1/3 only, then we call it mild. If it's up to 2/3 of the thickness, the basal 2/3, we call it moderate. If it goes almost to the surface, but not quite, we call it severe. If it goes all the way to the surface, then it's carcinoma in situ, and we wouldn't just call it dysplasia. So this is kind of the progression going with larger immature cells above the basal cell layer. This would be our mild dysplasia. It's getting thicker with the atypical changes, so that's moderate. And here it's severe. I would put a little more space between it and the surface than this one, but not much. It goes almost to the surface, but not quite. How does epithelial dysplasia look clinically? It's usually white. It's usually white because of the excess keratin on the surface, and clinically cannot be distinguished from benign keratosis. That's why we just refer to them as leukoplakias clinically, because they're just white patches that can't be wiped off and characterized as any other disease. And we don't know for sure what they are until we biopsy them. We just play the odds. And the odds are the most likely diagnosis is benign keratosis, and the second most likely diagnosis is epithelial dysplasia. But sometimes it's a small, rather innocuous looking little white patch. Sometimes they're extensive lesions. The more extensive the lesions, the more we worry about it being dysplastic, but you can't tell by looking clinically. A biopsy has to be done. Eliminate your local factors if there are any. We look for carcinogenic factors, so we would tell these patients stop smoking for 2 weeks, stop using alcohol for 2 weeks. I did an oral path consult just yesterday afternoon on clinic, follow up on a patient that had white gingival changes, and he was a smoker and using alcohol mouthwash, and he was supposed to only go 2 weeks, but he didn't stop smoking until the 2 week line. He got scared at his 2 week follow-up, so we gave him another 2 weeks to see if it would go away, and it didn't. So what next? Biopsy or revise your initial diagnosis. Maybe it was something different. Again.
The benign keratosis and the epithelial dysplasia.
Yes.
Dysplasia. How would you tell the difference? Just how much?
No, you cannot. The
You have
whole
to
point
biopsy.
is you cannot tell the difference clinically. You have to do a biopsy to know which one it is.
Okay.
Absolutely. Absolutely have to. So your differential diagnosis is your best guess based on the clinical presentation. You will not have a definitive diagnosis until a biopsy is done. And sometimes they just don't look like much. There was a slight little surface irregularity with some white and maybe a teeny red in the middle, but it didn't go away and didn't have a reason to be there. Do you think you could pick that one up on your oral soft tissue exam? Well, this was already dysplastic. It's already on the road to being malignant, so you better pick those up. They've done some really good studies in recent years that show the best way to identify these potentially malignant lesions is by clinical examination and training your eyes to see them. They have some shortcut things that are marketed to the dental profession that are supposed to help you find things. They are not as good as your own eyes. So hopefully you would see this. Would you see this one?
Yes.
And see how it's kind of leathery? A lot of times they get that sort of leathery look. But those are extensive lesions, a little bit of red too. And clearly the patient's a smoker. We see some lovely tobacco stains there. So are you going to have the patient stop smoking for 2 weeks? Yeah, that's usually good. Sometimes extensive lesions for the mouth, we don't wait 2 weeks. We get them scheduled with the surgeon as soon as possible, just because it's a very high-risk site. But it would not be wrong to wait 2 weeks if it's just white changes. Would you find this one?
Yes.
It's a little bit granular, a little white. The granular lesions tend to be a little more advanced. I'm always more suspicious of those, even when we can barely see them. And that was already dysplastic. Can you find the lesion in this patient?
It is light.
It is right here, this little tiny thing.
Wow.
But that's already premalignant. Already premalignant. So when you do your oral soft tissue exams, look carefully. And even if it looks like it's nothing, follow up and recheck them in 2 weeks. It's really important. If it's a persistent lesion, it needs attention.
Do some of these oral manifestations glow in like ultraviolet light or purple light?
Not ultraviolet light. There are special wavelengths of light that can make them autofluoresce or fluoresce. So the VisiLight system is one of the systems that shines the right wavelength of light to detect some of these. It's a little wand that you crack. You know, like the glow sticks for Halloween? It's like a glow stick, but it produces a specific wavelength that can identify lesions. But literally, it doesn't identify anything you can't already see, literally. And the Bell scope uses a special wavelength of light and that induces autofluorescence. And normal tissue fluoresces, and abnormal tissue, we get a dark field. And that one actually has some good research behind it that it does work, but it's a very expensive technology and still often doesn't identify anything you can't see. It can show that the lesion is bigger than you think it is clinically, but that's about it. Prognosis for epithelial dysplasia is guarded. It is premalignant already. It has at least a 15% risk of transforming to malignancy, but we cannot predict when that will happen or if that will happen. We have some rules for treatment and follow up with these patients. If it is mild dysplasia, we urge them to discontinue use of anything that might be carcinogenic, and they have regular follow-up, usually soft tissue exams every 6 months. If it is moderate dysplasia or worse, the standard of care is surgical excision of all remaining clinically abnormal tissue. So you have to excise the whole lesion if it's moderate or severe dysplasia. And then keep them on follow-up every 6 months for possible recurrence or new lesions. Carcinoma in situ means, you have that defined, that means that we have histologic features of malignancy, but it's confined to the epithelial layer. There is no invasion through the basement membrane, so it's not into the connective tissues. But in every other way, it looks malignant. More severe atypia and full thickness of the epithelium is involved. Why is it important to recognize this stage of malignancy?
Get it.
It's almost
It is a cancer. It's not almost a cancer. It is a cancer, but it's not invasive, and therefore it cannot metastasize. It has to go through the basement membrane into the connective tissue to have access to any of its avenues of metastasis. So it is the best time to find your malignancy. Best time. Clinically, these usually present as an erythroplakia or a speckled leukoplakia, meaning there will be red present, and it's usually the red part that is the carcinoma in situ. And histologically, we have severe atypical features that go all the way to the top, often don't even have hyperkeratosis. The cells are too atypical to make keratin. So one of the tests that we have for carcinoma in situ is flip it over. If you flip it over and you can't tell which is top or bottom, so that the top looks just like the basal cell area, then it's carcinoma in situ. Whereas there should be a little tiny bit of maturation of the top if it is severe dysplasia. So it is definitely worse than severe dysplasia. So this one mostly looks milky white, but it has that area of granularity. I always worry about the grainy ones because that's more advanced. So if I biopsied this, I would take the grainy area. This one is a thick white plaque, and it has some red in it. I would biopsy more than one part because this is a big lesion. The white is probably dysplastic, but could still be benign, and this would be the carcinoma in situ. It is not unusual because it is a progression of disease to have parts of a lesion in different stages of development in the same lesion. So it's not surprising for part of it to be benign, part of it to be dysplastic, and part of it to be carcinoma in situ. So big lesions, we usually sample more than one spot. And if there's some red, we take some red. If there's some white, we take some white to get the best representative diagnosis for the lesion and treat it appropriately. This one is mostly red and a little bit of white. And if you look at it, the red looks like just increased prominent vascularity. And that's really what's going on. Did you learn about angiogenesis with neoplasia? Cancer cells produce growth factors that stimulate growth of blood vessels because they need more nourishment. They exist to suit their own purposes, and that's why they turn red. It's because of the angiogenesis under the surface. What's the most common cause of redness in the mouth? Inflammation with hyperemia, which is different. Not more vessels, just dilated vessels. So this is distinctly different from the changes in vascularity that we see from inflammation. But the denture covers part of it, but not the other part. When this was biopsied, the red showed carcinoma in situ. Prognosis for carcinoma in situ is very guarded. It's already an intraepithelial malignancy. It could become invasive at any time. Standard of care is to excise all remaining clinically abnormal tissue with the lesion with a border of normal tissue. You have to get a border of normal tissue. But if you completely excise it, you have cured it. So that's the good news with carcinoma in situ. I want to back up. There was one more thing I wanted to say with this one. Can you predict how bad it is clinically? Sometimes. The thicker they are, the more likely the leukoplakia is to have some dysplasia, and the more granular or verrucous, the more likely it is to be dysplastic. The thinner and more uniform it is, the more likely it is to just be benign keratosis. Do you have to apply those rules for this course? No, but sometimes that information helps you guess. So sometimes we do get some clues, but you really can't tell unless a biopsy is done. So that's why we always do the biopsy and follow the standards of care. So if we have a white patch that shouldn't be there, doesn't have any local factors that are contributing to it, mechanical factors, and it persists, we have to biopsy it. If it's just hyperkeratosis, benign keratosis, we remove the cause, the smoking, the alcohol, whatever, monitor it. If it's dysplastic, we have rules depending on how severe it is. Usually excise and observe unless it's mild. Carcinoma in situ, always excise and observe and treat any recurrences. Squamous cell carcinoma goes to a much more extensive cancer surgery. So, more diagnoses. Do we want to continue or do we need a little break? Just want to get through it, okay. Nicotine stomatitis is a smoking-related lesion that occurs in the palate. It is a diagnosis that applies to the hard palate only. It does not apply to the soft palate. It has a distinctive clinical presentation. It is usually seen in individuals who smoke a pipe, sometimes cigars, sometimes cigarettes, but it is actually caused by the heat of the smoking. People who smoke a pipe smoke very differently than cigarettes, and they tend to inhale into their mouth. They just suck it into their mouth and they hold it there rather than inhaling it into their lungs. So the heat stays there and causes some injury to the tissue. So it's really related to the pattern of the smoking and allowing that heat injury to the hard palate. It produces some increased whiteness and also produces some inflammation of the minor salivary duct orifices. So we see little red spots on a white background. People who reverse smoke can also get what looks like nicotine stomatitis, but it has different implications. So knowing what they smoke and how they smoke it becomes very important. People who smoke cigars, regular smoking of cigarettes and pipe smoking, it's just ordinary nicotine stomatitis. And what's important about that is it has essentially no risk of developing malignancy. The risk of it developing malignancy is essentially the same as if it was normal appearing mucosa. The difference is way less than 1%. Way less. So what does it look like? It looks like diffuse white thickening of the hard palate mucosa with red spots at the openings of the minor salivary ducts because of inflammation under the surface. We also get some metaplasia and hyperplasia of the salivary ducts, and that can make it a little lumpy like this, but that's okay. When it extends onto the hard palate, we have concerns about atypical features, so we would not call this part nicotine stomatitis. Standard of care is nicotine stomatitis. Hard palate doesn't even require biopsy. We can tell the patient we see changes, the smoking's not good, please stop smoking, but we don't even have to biopsy it. If we see similar changes on the soft palate, we follow our same rules as we always do. Have them stop smoking for 2 weeks, reevaluate. If it's still there, biopsy, because it is a high-risk site. But isn't that beautiful? Yeah, white with red spots. So it's kind of an interesting disease. Is this nicotine stomatitis? We're really close up. I see some yes, some no. Mostly you haven't decided. It is a no. Why? It's because this is all on the soft palate. So this is a patient who smokes with his dentures in and has normal hard palate that's covered by the denture and has clinical changes confined to the soft palate because dentures don't cover the soft palate. And so these white and red changes and the little red fissures would just be erythroplakia, speckled leukoplakia, whatever you want to call it, and you would have to follow our protocols, and this would need to be biopsied if it didn't disappear. So this patient did stop smoking for 2 weeks, and where's my picture? There. This was 2 weeks later. Wow. What do you think? Would you biopsy or not biopsy? No. Is there any clinically abnormal tissue remaining? Or did it completely go away? There's still some there. Look carefully. Most of it went away, but there's still some white here. There's still some white over here. This patient would need to be sent for biopsy, so look carefully. Always look carefully. The biopsy was benign keratosis, so this patient was getting away with smoking. Best time to say, oh, you quit for 2 weeks? Never go back. If you can do it for 2 weeks, you can do it forever. That's what I tell them. We move on to smokeless tobacco keratosis. This is the diagnostic term that occurs in patients who use spit tobacco, a non-smoked tobacco product. Comes in different forms. It comes in a little leafy kind of stuff, ground white powder we call snuff. Comes in moist snuff and dry snuff and the little leafy kind. There are a whole bunch of different kinds. The moist snuff I have to think about it. One of them has less risks for cancer. The moist, I have to look it up. I always forget. So I'm not going to say. But anyway. Lots of people use smokeless tobacco. And the age at commencing the habit can be very young, particularly in the southeast of this country. Usually, if they're going to use it, they're using it by age 10. Yes, by age 10. In California, it's usually a teen thing, not by age 10. They're really marketing to girls. It's like, why? Yes. It's like, goodness gracious. Anyway, we don't have a lot of good studies on the risk of malignant transformation for smokeless tobacco keratosis. One study said 0.4% over time. We believe that is an underestimation. But it is important to recognize that it does have a lower risk, significantly lower risk of malignant transformation compared to smoked tobacco. But it is not a zero risk, and we still have to be concerned and we still have to follow up. Most patients place their smokeless tobacco in a specific spot, usually a mandibular vestibule, usually right in the same place. Some of them get smart to it looks different when I keep it here very long, and they might move it around, rotate their locations. But they don't usually have lesions everywhere in their mouth. It's going to be here in the buccal vestibule or the lower anterior mandibular vestibule. The dry snuff, sometimes they put in an upper vestibule. all of the other forms they usually put in the lower vestibule. Do they ever put it under the tongue? Virtually never. That's not the habit, so it's a vestibule. Put it in a vestibule. And it produces kind of white wrinkly changes that are somewhat leathery and often has these kind of fissures or grooves in it. It's very, very, very common. It produces gingival recession. So we typically see gingival recession, staining of the exposed roots. It can have tooth sensitivity, bad breath, ugly spit, a lot of nasty things. But it's not usually just the mucosal changes alone. Regular use does cause a lot of periodontal harm. So that is smokeless tobacco keratosis. We manage it the same way we manage our other white lesions. We have them stop using the product for 2 weeks and reevaluate. If it persists, we do a biopsy. If it all goes away, then we tell them, good job, you quit using your smokeless tobacco for 2 weeks, you don't ever have to go back to it. What do you do if they go back to it? At least once a year you do the stop tobacco for 2 week test. One of the interesting things about the smokeless tobacco keratosis lesions is that part of the lesion is actually chemical burn. It's not all hyperkeratosis, and that is because of the direct contact with the product, and it is a little bit caustic. It's caustic enough to damage the gingiva. It's not surprising it can cause a chemical burn as well. But the chemical burn part usually heals very quickly. It will heal in 10 days to 2 weeks. So if there's anything left behind, we do need to do a biopsy. So that's how we manage them. Tell them to stop using it. And I love this case because of the braces. This is an adolescent, still in braces, using spit tobacco. Do I need to tell you that they're using spit tobacco? No, because the lesions are very typical. And we often see a little bit of the product stuck to the teeth. Did you notice that on the other ones too? A little bit of product and staining. So we can usually tell what's going on even if I don't give you that history. Question?
Was that your patient with the braces?
No.
Oh, okay.
You're going to ask a question about the patient? No.
I was going to ask if the parents knew and they just found out.
Oh, now, if the parents know or don't know, that's a tricky situation. Because as minors, you kind of have an obligation to tell family, but
It's the same as like chewing tobacco?
yes, chewing tobacco or spit tobacco is the
It's
same thing as smokeless tobacco. All the same, all different names for the same kind of products. I think the most popular term right now is spit tobacco. So I'm not sure. It changes. So are we going to biopsy this or not biopsy it? I don't think I'd biopsy that one. It is a little paler, but I don't know. I might go another week, see if it completely heals. Sometimes I will extend it another week if there's good improvement but not complete resolution. Yes.
What do you tell your patient? Like, do you tell them that it looks like it might be precancerous?
I'm upfront with patients that have smokeless tobacco-related lesions or tobacco-related lesions, that these white lesions, we don't know what they are by looking at them clinically, and there is a risk of them being malignant or pre-malignant. I'm upfront with them that if they're just a white plaque or just the white surface changes, that they're usually no worse than pre-malignant, but they could become malignant over time, and that the only way to know really what's going on in the tissue is to do a biopsy. A lot of patients don't want to have a biopsy and are quite willing to stop using their tobacco product for 2 weeks to give it a chance to heal. If they know healing and if it completely goes away, they can avoid a biopsy. So, but I'm upfront with them. This could be pre-malignant already, and we have to follow up with it. There is a risk there.
Would vaping provide the same kind of effect?
Would what?
Vaping?
Vaping. We don't have a lot of research on vaping yet. We know that vaping causes a lot of lung injury, but we don't know everything about that. The propylene glycol and the flavoring agents are a huge part of that. But the problem is it's not regulated, and nicotine always comes from tobacco, and we don't know what the level of contamination is with carcinogens. And vaping hasn't been popular long enough for us to have some good studies. Because in patients who do get malignancies related to tobacco products, it can be related to decades of using a product. And vaping hasn't really been out that long, so we're waiting for data, but we do not believe it's innocuous or harmless. We have some good reason to believe that it's not innocuous or harmless. We just don't have hard data yet. So they're working on it.
What do you tell a patient if, like, they're using spit tobacco and they have these white lesions? They're like, oh, I don't care, nobody sees these lesions, I'm just going to keep going. I mean,
If they keep going and they don't care if they have the white lesions, you're obligated to do a biopsy. You're obligated to do a biopsy. That is the standard of care. And in the state of California, the dentist cannot allow a patient to consent to less than the standard of care. That is malpractice. It doesn't matter what they want. If it's less than the standard of care, it's malpractice. Okay, moving on to actinic cheilitis, also known as actinic cheilosis. Tradition says it's cheilitis, but itis means it's inflammatory, and that's really not the problem going on. You can also call it actinic keratosis. That's the term that's always used for the equivalent lesions on the skin. Sometimes we use the term solar keratosis. CHEIL means lip, so this is a disease on the lips that's related to chronic sun exposure. Actinic means from the sun. And it is a premalignant process. And just like the intraoral lesions we've been looking at, you cannot tell by looking at it where along the spectrum it is. And these lesions, if they persist, do require biopsy. It is caused by accumulated sun damage to the epithelium and supporting connective tissues. And most patients are middle-aged and older who have spent a lot of time outdoors for many years, either a lot of outdoor sports or they have an outdoor occupation. And so they've had a lot of sun damage and haven't been using sunscreen on the lip and adequately protecting it. There is greater risk in individuals who are very fair-skinned because they have less natural protection from sun damage. Up to about 25% of patients will eventually have malignant transformation of these lesions, so there is a good risk of cancer in the lip. So we have to follow up carefully. Actinic keratosis is almost always on the lower lip only because of the way the lower lip catches the sun rays. And the sun damage produces white plaques. Sometimes they're very discrete and sometimes they're very diffuse and ill-defined. They can be localized or more generalized. Because of the damage to the supporting connective tissue, it also effaces or obscures the normal border of vermilion lip to skin. So usually we have a clean, sharp, clear transition from vermilion lip to skin. But in actinic cheilitis, it's kind of blurry and hard to see exactly where the transition is. See how that it's altered? In some patients, this one was benign keratosis when it was biopsied. Sometimes we just call it benign actinic cheilitis too. But no worse than just benign hyperkeratosis was present. Sometimes it presents with a crust on it, and patients think that it's just chapped. And they'll say, oh, my lips are always chapped. Well, you shouldn't always have chapped lips. So we try to protect the lip and follow up in 2 weeks. We follow that 2-week rule again. So what can you do to protect the lips from sun damage? Sunscreen. Chapstick with sunscreen. And even men can use chapstick with sunscreen. You want the highest level of sunscreen you can find. So you might need to use one of the facial sunscreens and just smear it on the lips and then put chapstick on top of it. And then follow up in 2 weeks. If it was chapped lips, it would heal in 2 weeks. I also tell patients to put Vaseline on their lips at night. Make sure they're using plenty of moisturizer to give their lips a chance to heal. And if it's still changed and clinically abnormal in 2 weeks, then we send them for a biopsy. This one was already squamous cell carcinoma. There was some invasion there. And this one was just epithelial dysplasia. So the diagnostic term you might get back on your report is actinic cheilitis with dysplasia, with mild dysplasia, moderate dysplasia, severe dysplasia. So we talked about patient management already. There are lots of treatment options, but if there's any dysplasia, we do have to treat. They can use chemical peels that destroy the abnormal tissue and then it regenerates healthy mucosa. Cryosurgery. There is a medication called topical 5-fluorouracil. It is abbreviated 5FU, but don't use that when you're talking to your patients because they might think you're saying something else. But that is a chemical that stimulates the immune system to destroy the abnormal cells and has to be repeatedly applied for a period of time to be effective. They can excise the vermilion lip. They call that a vermilionectomy. And then they advance the intraoral mucosa to create a new vermilion lip, get very good aesthetic results. Amazing. And they can do a lip shave as well. So there are a lot of different options. You send them to the oral surgeon who selects the best options for the extent of disease in the patient and that the patient is willing to accept. Patients with a history of actinic cheilitis need lifelong sun protection on the lip and regular follow-up to evaluate for recurrence and new lesions. So every 6 months, absolutely have to have a careful examination of the lip. Squamous cell carcinoma, we are finally to the biggie. The one that accounts for at least 94% of oral cancers. We use the term squamous cell carcinoma when it is invasive. We have atypical changes and proliferation. It's invading through the basement membrane and it is into the supporting connective tissues. We already talked a little bit about the statistics, so I don't want to go over those statistics again. But we do want to talk a little bit about typical patients. Historically, oral squamous cell carcinoma, soft palate and anterior, and including vermilion lip, has been most often in men over the age of 40, but the demographics is changing. We are seeing more oral cancers in patients under age 40. We're seeing more oral cancers in women than we have before. And so basically any patient over age 20 could get it. And we even see oral squamous cell carcinomas in patients who have no risk factors, no identifiable risk factors. So when we see those precursor lesions like leukoplakia and the patient has no risk factors at all, no smoking, alcohol, no local mechanical factors, nothing, we're actually more suspicious than if they had a smoking history because we know that they can get them. Tobacco and alcohol are the leading risk factors. HPV, human papillomavirus, particularly 16, and sometimes 18, but particularly 16, is seen in a small number of cases. What did you learn from Dr. Grandi that HPV 16 is related to? Oropharyngeal cancer. So oropharyngeal cancer would be on the tonsillar pillars posterior to the line of the edge of the soft palate. So in the tonsils, in the base of the tongue, occasionally on that posterior pharyngeal wall. It is very commonly in the tonsils, and it's in the crypts of the tonsils. So if you do your oral screening exam and are looking at the tonsils, are you going to see a white patch? No. So we can't really usually find the precursor lesions for oropharyngeal carcinoma. So we don't usually detect it until it's already an invasive squamous cell carcinoma. So then how do we detect it? One tonsil is bigger than the other. We should have a very high level of suspicion anytime one tonsil is bigger than the other, and that requires follow-up every single time. We send those to ENT and those need to be biopsied. Another thing that we know about oropharyngeal cancer is that it tends to metastasize earlier. And sometimes we find it by a positive neck node, a firm, indurated, enlarged neck node with no oral lesion. Those require immediate referral for biopsy of the lymph node. The interesting thing also about oropharyngeal cancer is that it has a better prognosis than our traditional smoking-related oral cancers. They usually treat it by local excision if they can and follow up with radiation, and it responds very, very, very well. Very, very well. Even if it's already metastasized to a neck node, it has a better prognosis than oral squamous cell carcinoma. So doing our appropriate screening for neck nodes and asymmetric tonsils is very, very important. You can save a patient's life, but don't be expecting to see a white patch because that's not how it presents. We see the white patches and the red patches and sometimes a mass in oral lesions, but not oropharyngeal lesions. Back up. One more thing about, or two more things about oropharyngeal carcinoma. More common in men, more common under the age of 40. So definitely in that little bit different age group too. So keep that on the back burner as well. Questions? Think you're first.
Are the lymph nodes, do they always have to be fixed, or
They are firm and non-tender, not just rubbery and tender. An enlarged rubbery and tender lymph node is reactive, doing its job with the immune system. Not suspicious.
okay.
But if you have persistent enlargement of a neck node and it's firm, and definitely if it's fixed, it requires immediate attention. Never ignore that. Never ever. All right, this is histology for squamous cell carcinoma. It's arising from the surface epithelium. It's invading into the connective tissue. This one's well differentiated, still really looks like squamous epithelium, so that's pretty good. This one has been tunneling under from the side, still also very well differentiated, even makes keratin. It's got some keratin pearls in it. The better differentiated it is, usually the less aggressive it is, so that's always good. It is important that you know the sites of predilection for our oral squamous cell carcinoma. This is based on biopsy and excision specimens and just doing the studies. Where do they most often occur? Based on knowing where they most often occur, that establishes our risk sites. Single most common location for oral cancer is vermilion lip, which is a different beast. It's that sun-related one. It's also the place with the best prognosis because we can find it earlier and it can be excised. We actually have a 90% plus cure rate, long-term cure rate, not just 5-year survival, but long-term cure rate for lower vermilion lip. But 35% of them occur there. When we're talking about intraoral sites, most common site and highest risk site is ventrolateral tongue. Close second to that is floor of the mouth. A distant third is soft palate. A very distant fourth intraorally is gingiva or alveolar mucosa. Buccal mucosa, only 1%. And all other sites are even less than 1%. So our top sites are vermilion lip, ventrolateral tongue, floor of mouth, and soft palate. And definitely intraoral sites, those three, need to know them in order. So if I ask you a question about sites of predilection and risk sites and ask you to rank them, please pay attention to the wording. If it just says oral cancer, that includes vermilion lip. If it says intraoral cancer, that does not include vermilion lip. So pay attention to how the questions are asked. So these were both invasive squamous cell carcinoma. Would you have a suspicion in this patient?
Yes.
Maybe, but it looks more like our ordinary actinic cheilitis that might be still benign or dysplastic. So you might be surprised. And that's why we always biopsy for these persistent lesions. It could already be an early invasive squamous cell carcinoma. If we palpated this and this was indurated or very firm and fixed in this area or anywhere else, then we might have more of a suspicion, but sometimes there are no palpable changes either if it's early invasive, because it's just literally just a few cells that are already invasive. Should you be suspicious of invasive carcinoma for this one? Absolutely, because there are mass effects. The lip is enlarged, has abnormal architecture, has a little ruffled edge to it, as well as the surface changes in the crusting. So if I showed you this case and you told me actinic cheilitis, I would be most unhappy, because this is way past actinic cheilitis. This has mass effects, and you should be able to recognize this as an outright carcinoma at this point. Do you think you could? Of course you could. Yes, you could. I don't want to see any nose. You guys have good eyes. So this one, it was actually carcinoma in situ. Oh, now this was one of my patients. I do have a little story with him because he was very cute. He was a veteran, and he was very fair complected. He went on a fishing trip and got a bad sunburn. The bad sunburn triggered a herpes lesion on his lip, so he had recurrent herpes labialis, and it never healed right. And it developed a little plaque, and then the plaque got bigger and started spreading, and he was very concerned. So he called up the VA here in town, because he was a veteran and had benefits, and said, I've got this thing on my lip and I really need to see the doctor and have it evaluated. And they said there's a 6-month waiting list for an appointment. 6 months. So what does he do? He shows up at the dental school for urgent care. I got to get somebody to look at this. So I got called down for an oral path consult, and I saw this. And it's definitely a thickened area. Definitely elevated. And I did not like it because it extends onto the skin. This is the border from the vermilion lip to skin. And this is part on vermilion lip and part on skin. So that is indicative of an invasive spreading process. Actinic cheilitis doesn't do that. That's a malignancy. We actually did the biopsy on him the same day. We did not let him go home without a biopsy. And it was a superficially invasive squamous cell carcinoma. It was more than microscopic invasion, but it was still pretty superficial. We referred him to head and neck surgery. We got him in later the same week to see the head and neck surgeon. And he elected to be treated with radiation because it was kind of big and they were going to take out about half of his lip if they did surgery. And he didn't really want that. He was recently widowed, and he was thinking about getting back on the dating scene, and he really didn't think he could compete with the other old guys with only half a lower lip. So he elected to have radiation treatment, and about 6 months after his treatment was completed, he came back to the school so he could show me his lip. He was very happy with the results, and he said that, I swear this is true. This is what he said. He says, and Dr. Richards, he says, now I can kiss the ladies. Oh, it was really cute. I'll never forget him. Now I can kiss the ladies. Yep, that's what he said. What about this one? Would you be suspicious that this is already malignant? He has a little white lesion and a little crust in the middle, but his snaggletooth fits right in it. And so there was a suspicion that this was actually related to chronic physical trauma, might be a chronic traumatic ulcer. But protecting it from the tooth didn't make any difference. It was biopsied, and this was already invasive squamous cell carcinoma. So we often have a hard time distinguishing between innocuous things like physical injuries, chronic physical injuries, and squamous cell carcinoma. That's one of the things that you learned from Dr. Grandi. What about these? Would you call these leukoplakias? They look uglier, thank you. This one is a little weird one. It's got some red areas in it, so I call this one maybe a speckled leukoplakia, but this was still all on the surface, had normal consistency to palpation and no mass effects. So I would call this one a speckled leukoplakia. This one You notice the retraction, and it looks a little lumpy. If there are mass effects, you do not use leukoplakia as your descriptor or erythroplakia. That's when you go straight to, it's probably squamous cell carcinoma. So, and this one actually was a squamous cell carcinoma. This one was epithelial dysplasia, and this one was squamous cell carcinoma. But I'm not surprised because it looks different. It has some mass effects. What about these? See how it's a little lumpy bumpy? It's not just a white patch or a red patch. It's a little lumpy bumpy. So you should be more suspicious. Especially if you palpate it and it feels firm. That's not a leukoplakia anymore. This one was already squamous cell carcinoma. This one you can see the lump under the surface. It's white on the surface but a lump underneath, and it was firm and indurated. It's not a leukoplakia. That's a mass. And so you go straight to squamous cell carcinoma as your primary clinical diagnosis. Notice the retracted area as well that's pulling in. That's a suspicious sign as well. Would you call this an erythroplakia? No, because it's not a patch. It's got thickness. It's got thickness. There are some mass changes. What about this one? And that was a squamous cell carcinoma. That's an outright squamous cell carcinoma. What about this? What would you call that clinically? How would you describe it clinically? I would probably call that a speckled leukoplakia. There's a little bit of white and a little bit of red. It was normal to palpation, no mass effects. So you just build your differential. What's your differential for speckled leukoplakia? At least dysplasia. I like, if there's any red in it, I like to see carcinoma in situ, followed by epithelial dysplasia. If there's red in it, the likelihood of it just being benign keratosis is very small. I would only put that on the differential if you have 3, if you're going to go longer than 2. Top 2 have to be more advanced diseases. And that's where the differential was built, and the patient was referred for biopsy, and that was already early invasive squamous, microscopic invasion, squamous cell carcinoma. What about this one? What would you call that one clinically? How would you describe it? That's a mass. What's right next to it? A white plaque. So here we've got some leukoplakia. This is not red, I don't think. That's just the normal color on the side of the tongue. But here we have a mass. So which part are you going to biopsy? The white patch or the mass? You can do both. How much are you going to excise? All of it. Because that's definitely squamous cell carcinoma. And this is probably premalignant. And they're gonna do a wide excision there. Soft palate tonsillar area. It's hard to see where the boundary is, but I think this started anterior. So that would still be an oral cancer, but notice that it's got irregular contours. You can see some mass changes. So that's not an erythroplakia or a speckled leukoplakia. That's a mass, and you can palpate it, and it's firm, and it's fixed and indurated. And that was a squamous cell carcinoma at a very high-risk site. Gingiva, low-risk site, looks like an ulcer. Would you suspect that that's squamous cell carcinoma? Probably not. Do you really see a mass?
Yeah.
Maybe, sort of. Have you learned any reactive things that produce masses on the gingiva? Yeah? Does this look like pyogenic granuloma? Those reactive things usually involve the gingival margin, not away from the gingival margin. But I'll tell you the telltale clue on this patient, there was some mobility of these teeth. Because it's invading the bone underneath and damaging support for the teeth. But if you didn't have that information, I would not be surprised if you did not suspect malignancy. But any lesion that persists and doesn't go away, you're going to send for biopsy. So they figured that one out. This one is kind of a well-defined thickened plaque, palpable thick plaque, so it's firm. That one ended up being squamous cell carcinoma. This one looks like nothing. And it was biopsied because it persisted. It did look a little grainy, but it ended up being early invasive squamous cell carcinoma. So sometimes things that look like they're nothing are already cancer, and that's why we're suspicious of everything and follow the rules and follow up, and if it's still there, and we've eliminated every local factor we can, then we do a biopsy, because sometimes it's something important to find that needs immediate attention, immediate treatment, and other times it's not. We cannot tell by looking, so we have to do a biopsy. Do you need to do a biopsy to know that there's something significant going on here? So I should have had this advanced. So this looks like periodontal disease, teeth flapping in the breeze, but then when you look in the floor of the mouth, there's this huge fissure and a fungating mass at the edge of the fissure. This has all been destroyed by the cancer invading and destroying. So cancers invade and destroy normal tissue. They're very destructive. So how likely are we to cure this patient? Not likely at all. This is a very advanced squamous cell carcinoma, and you can't even really tell the site of origin for sure. Maybe floor of the mouth, but you can't tell for sure because it's very large. So that's why we're suspicious of the little things, so we can catch them and intervene before they get like this, because this is going to kill the patient. And this one's so advanced, it's probably sooner than later. Treatment. Treatment of choice for squamous cell carcinoma is surgical excision, wide surgical excision with a generous border of normal tissue. They do check for nodal involvement, so we do staging using the T&M system that you learned from Dr. Grundy. And if there are lymph nodes involved, they will do a neck dissection as well, and more extensive excision. If there's no nodal involvement, then they may just do a local excision, but you do have to stage the patient to find out the extent of disease before planning surgery. This is a patient who had excision that included part of the mandible, so there's no bone underneath here, no support to hold the tissues out, but he at least was able to keep some of his tissues. See the scar on his neck? They took out the nodes, internal jugular vein, and some of the muscle, sternocleidomastoid muscle on that side. A lot of times they are doing modified radical neck dissection these days, a little more conservative, because we have better techniques for staging and determining how extensive the disease is. And so that's really good for patients, because sometimes these radical surgeries are more miserable for the patient than living with the results than the disease might have been. So it's not a fun disease to have, and even after treatment, not a fun disease. I've seen patients where they excised half the tongue and the floor of the mouth and sutured the edge of the tongue to the alveolar crest. Took out all the teeth on that side. It's like, how do you function when you can't move your tongue on one side because it's sutured to your jaw? It's very, very challenging for these patients. So early detection, when you can treat with more minor therapies that give patients more tissue left and better function afterwards, is always better. You're not only saving their life, you are also saving their quality of life. And so that's why we're so diligent with those soft tissue exams and fine lesions early. I am going to let you look at the prognosis things, but the prognosis is based on stage and advanced lesions with metastases as low as 5-year survival of only 20%. And we can have good survival if we catch them early. So early detection is always better for the patient. So what do you think about the prognosis for these patients? Didn't I tell you that vermilion lip is the most curable place with the best long-term prognosis? 90% cure rate. Did he make it in the 90%? No. This is a very advanced lesion, and from the color changes here and the swelling, we know that there's already lymphatic invasion, which means there's metastasis to lymphatics. So this is very advanced, probably not curable at this point. Maybe remote chance of cure with surgical excision and radiation, maybe. This one, very large lymph node with metastatic disease in it. Maybe still curable because it looks like just one node. Maybe still curable. But look at this patient. 1, 2, 3, 4, 5, 6, 7 nodes that we can see visibly. How many others are palpable? Chances of cure getting pretty slim at this point. So finding out when the stage is earlier is much better for the patient. I thought I saw a hand for a question, but I wasn't sure.
I was just gonna ask if like the main reason that they wait so long to come in is it like psychological or like clearly that didn't just like pop up overnight.
Part of the problem is they're men that get these more frequently, and men do not avail themselves of health care as frequently as women. They don't go for exams and see their physician, and they often don't go as regularly to the dentist. So sometimes the patients who are at highest risk are the ones that we don't get in the office to actually do our screening. That is why the American Cancer Society and the American Dental Association really push community screenings so we can pick up more people and pick up people who aren't getting into the healthcare avenues to be properly screened. And we also have this phenomenon that I have never understood, but I've seen it many times. And that is patients know something's there, but they play this psychological game. As long as I don't know what it is, it can't kill me. As soon as I find out what it is, I'm going to die. And that is a very foolish choice because early diagnosis is the best opportunity for survival. We have a couple more cancers that we can cover quickly. One of them is verrucous carcinoma. It is a variant of squamous cell carcinoma that is distinct both clinically and in terms of histology and behavior. It is way less common than regular squamous cell carcinoma. So why do we care? Because it has a better prognosis. So this is a pattern of carcinoma that invades with a pushing border and very rarely metastasizes. And because of that, it can be cured by local excision. Don't even have to be as radical with the excision as regular squamous cell carcinoma. So the overwhelming majority of patients with verrucous carcinoma will survive their disease. So it's good news when you get a diagnosis of verrucous carcinoma in the oral cavity. It is different in that it is strongly associated with long-term smokeless tobacco use, particularly that dry powdered white snuff that little old ladies in the South used to put in the upper vestibule because it wasn't socially acceptable to smoke. And you could use your tobacco very discreetly. The big brown leafy smokeless tobacco that you put the big wad in your cheek, those proper little old ladies weren't going to use. You know, but women could get away with using the white powdered dry snuff because they could use it discreetly. So that's one that strongly correlates with development of verrucous carcinoma, but we do see it with other forms of chewing tobacco and sometimes in patients without identifiable risk factors. Histologically, the tumor is very well differentiated. Sometimes not even as much atypical cellular features as we see in dysplasia. It may look like mild dysplasia, but we have these proliferative changes and finger-like extensions pushing into the deeper tissues. We get these, where's my pointer? These papillary surface changes, so it grows up from the surface and into the connective tissue. It has a lot of excess keratin, so it's usually a white surfaced mass, and these deep clefts in between the papillary projections. So it's very distinctive histologically, but with a limited biopsy may not even be recognized as being malignant. Here is one that ended up on the buccal mucosa just inside the vermilion lip as a thickened, kind of firm white plaque. But was kind of indurated and fixed. This is one that was in the upper vestibule, one of those ladies using snuff. And it's white and it's kind of warty looking. Do you see the raised rolled edge to it? Definitely a mass. That is not a leukoplakia. We have a mass there. But that ended up being a verrucous carcinoma. See how well defined it is too? It kind of stays together a little better than our regular squamous cell carcinoma. This one's a very interesting lesion. This one was a male and had a lesion on the gingival margin. And it did look like a wart. And the tooth behind it was mobile, advanced periodontal disease. So the general dentist referred this patient to the oral surgeon for surgical excision of the wart and extraction of the tooth, the periodontally involved tooth that couldn't be saved. So the surgeon removed the wart first. There it is, all gone, excised. Took out the tooth and found that the entire internal surface of the socket was white. Biopsied that as well. This was a verrucous carcinoma, and the wart was verrucous carcinoma, and it had invaded down the PDL of the tooth and was the reason for the mobility. So how do you excise it now when it's in the socket?
Cut out the socket.
You have to cut out the socket. You have to take out a chunk of bone that contains the socket in order to remove it. That's the only way to get a clean margin. Yeah, real fun. Real fun. Last one, basal cell carcinoma. It is not an oral cancer. Basal cell carcinoma does not occur in the mouth, and that is because it actually arises from malignant transformation of epithelial cells of the hair follicle. They have a basal cell appearance because hair follicles have basal cells. So it's called basal cell carcinoma, but it arises exclusively on hair-bearing skin. We do not have hair follicles in the mouth, gratefully. Every now and then they'll do repair of an intraoral defect, a graft from hair-bearing skin, and you can end up with hair in your mouth, but it doesn't naturally occur there. So this is a skin cancer. It is the most common skin cancer. And why do I care if you know about it? Because the site of predilection is mid and upper face, the part that we're staring at when we're working on our dental patients. So we are in the perfect position to screen for it. And when we find skin lesions that shouldn't be there and are suspicious for melanoma or basal cell carcinoma or even squamous cell carcinoma in the skin, we need to advise patients this has to be checked by your physician, and don't wait. So the most common one that you're going to see on the skin is basal cell carcinoma, and it often starts as in very fair-skinned people, and it is due to long-term sun damage, so they're usually middle-aged and older fair-skinned people who don't have good protection. I am in that high-risk category for basal cell carcinoma. I just stay out of the sun. Hopefully I won't get one, but anyway. They start as something that maybe looks like a pimple, but it never completely heals. And they get a little crater or crust in the middle. The edges tend to be a little bit rolled, sometimes have a pearly appearance, and we sometimes see some delicate blood vessels in the lesions. I'm not sure how important it is that you know about nevoid basal cell carcinoma syndrome. Your boss, the dentist, needs to know about it. It is a hereditary disease that, as part of the syndrome, has multiple basal cell carcinomas starting at a very young age. Instead of over 40 age group, it's under 20, and lots of them. So if you do have a patient in your practice who has a history of nevoid basal cell carcinoma syndrome, we check the skin much more carefully and advise the patient of anything we see so they can get it checked right away. Here's another one, right in the groove on the edge of the nose, but see how it's depressed in the middle with a raised rolled border? And they progress very slowly. They can be present for months to years and slowly enlarge. They almost never metastasize, just like verrucous carcinoma. So it's unusual for a patient to die from basal cell carcinoma, but if you ignore it long enough, it can do some really bad harm. And that concept, as long as I don't know what it is, it can't hurt me, applies. When I was a resident at County Hospital in Los Angeles, We had an older woman come in to the hospital. Her daughter brought her in and made her come in finally. She came into the clinic with a paper bag over her head because she didn't want anybody to see her. She had a basal cell carcinoma that literally covered half of her head. It's very large. So these are easily excised and cured when they're small, but you cannot excise half of a person's head without consequences. And they do invade and destroy, and they can destroy the bone underneath and can get into the brain area. So they should not be ignored just because they're growing slowly. This was a patient we saw here at the School of Dentistry a few years back, 53-year-old female, aware of this lesion on her cheek for 9 years. Watched it slowly enlarge for 9 years. Do you see the blood vessels in it? There it is. See the delicate blood vessels? A little crust right here, and that raised rolled border with kind of that pearly or waxy appearance. Very, very common presentation for a basal cell carcinoma. Question?
No, it's actually a statement. I just want to say it can happen to like young people too. Because I have a friend, he's 29 and he had that.
He got one?
Yeah, it is on his nose.
On his nose.
He had to take it off, but it could happen to anybody.
It could. Especially in Southern California where we are sun worshipers from a very young age. Go to the beach, go surfing, don't wear enough sunscreen. But most patients are middle-aged and older. And this one last patient, this was also a patient here at the School of Dentistry, older gentleman, came in for his dental exam with a Band-Aid on his nose, and the perio instructor said, "What's under the Band-Aid?" "Oh, it's nothing, I know what it is. Just ignore it. I just want my teeth fixed." And the perio instructor said, "No, I want to see what's underneath it." And that's what it looked like. Side view, look at that. See, it is an invasive destructive cancer. But it just progresses slowly. A Band-Aid will not cure it. He says, "Oh no, by the way, I have another one on my forehead under a Band-Aid there." So we told this patient, it's time to go in. You got to go see your doctor for this. We'll take care of your teeth, but you go get this taken care of first. Question?
Did you actually know that? Like, he said like.
Oh, he knew it was a cancer. He knew it was a skin cancer. He just was thinking the longer I ignore it, the better for me and the longer I'm going to live. I don't understand this mentality, but they do it. Patients do it. Wow. So this one, they did a graft, a skin graft. The ones in that location are kind of hard to treat. What is the prognosis and treatment for these? Yeah, pretty bad. So these are really, really old cases. With access to care, there is no excuse for this to happen. But sometimes patients, if it doesn't hurt, oh, it must be harmless. It's growing slowly, imperceptibly. They don't think about it being persistent and being there. So it's really important to advise them when we see things. Get this taken care of now when it's small and easy to treat. And now we're done. I am sorry for keeping you here. I'm sorry about the power outage. I will see you all at 1 o'clock or 2 o'clock or 1:30 or whenever your appointment is this afternoon.